Good afternoon and welcome to today's presentation, Abdominal Emergencies. The information presented by the expert is not to be used as legal advice and does not indicate a working relationship with the expert. All materials obtained from this presentation are merely for educational purposes and should not be used in a court of law sans the expert's consent, i.e. a business relationship where she or he is hired for your particular case. In today's webinar, Dr. Cohen will discuss demographics of abdominal complaints, social and economic impact, abdominal emergencies every ER doctor and malpractice attorney needs to know, malpractice, disability from misdiagnoses, duty of providers and standard of care, and documentation. To give you a little background about our presenter, Dr. Evan Cohen is a board-certified emergency physician. He completed his emergency medicine residency at Cooper University Hospital in Camden, New Jersey, and has been practicing emergency medicine for the past 8 years. He is currently the Associate Director of the Emergency Department at New York Presbyterian Hudson Valley Hospital. Attendees who require a passcode, the word for today is abdominal. During the Q&A session, we ask that you enter this passcode into the Q&A widget for your CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you are applying for CLE credit, you must log on to your computer as yourself and stay for the full 60 minutes. You are also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with a link to the archived recording of the webinar. The slides can be downloaded from the resource list at the widget at the bottom of your screen. Thank you all for attending today, and Evan, the presentation is now turned over to you.
Thank you, Lauren, and good afternoon, everybody. I'm Evan Cohen, and as Lauren mentioned, I'm going to talk a little bit about some of the critical abdominal emergencies that every ER doctor and attorney that deals with these sorts of things should be familiar with. So we're just going to, and please, if people have questions during or in the middle, please feel free to interrupt or chime in. Just starting with a little bit of basic anatomy. When we talk about a patient's abdomen, or anatomy, we're talking about from their perspective. So in this picture, the patient's right is on our left, and basically the abdomen is everything below the diaphragm. So on the right upper, it's divided into 4 quadrants. We have right upper quadrant where the liver sits, left upper quadrant where the stomach sits, and then right lower appendix and left lower quadrants. So abdominal pain is an important topic. It's a very common cause of visit to the emergency department. 5 to 10% of all ER visits are for abdominal pain of some sort, and it represents a disproportionate high number of admissions. So between 20 and 40% of all admissions to the hospital are with abdominal complaints. Almost half end up being diagnosed with something called abdominal pain NOS, or not otherwise specified, which means that we don't find an answer to what causes the pain. The good news is that 80% or so are going to get better within 2 weeks with no definitive diagnosis or treatment. And the exception for this is in the elderly population, meaning people over 65, where abdominal pain as a symptom carries a very high mortality rate, about 8 times as high as non-elderly. And about 1 of 3 patients coming to the ER that are elderly with abdominal pain are going to require surgical intervention. It's obviously important for many reasons, but we think of the missed days of work that abdominal pain causes in regards to delayed diagnosis, the need for reoccurring doctor's visits, hospital visits, tests, the ongoing pain, and sometimes what leads to a pain use disorder, and the importance of delayed surgical correction, which can lead to a much more complicated healing process and complexity of surgery. So we're going to talk about the following diagnosis. There's obviously many other that are crucial for ER doctors to know, but these are some of the common and most critical. Appendicitis, abdominal aortic aneurysm, bowel obstruction, abdominal perforation, renal obstruction or kidney stones, ectopic pregnancy, diverticulitis, and mesenteric ischemia. So we'll start with a case. A 20-year-old male comes with mid-abdominal pain for 12 hours. On exam, he has mild pain, a slightly elevated white blood cell count, He has a CAT scan abdomen pelvis that's normal, and he's discharged to home, instructed to follow up with his primary care doctor. On the next day, he returns to the ER with continued pain and nausea. No further diagnostics are done, and he's diagnosed with gastroenteritis. And on day 3, he comes to the ER with diffuse peritonitis, which means rigid abdomen, tenderness all over the abdomen, elevated white blood cell count, and a repeat CAT scan shows ruptured appendix. He requires an open appendectomy, 10 days of hospitalization, a post-op ileus, which means the bowel is slowing down or shutting down, antibiotics for infection, and then develops Clostridium difficile diarrhea. So this leads us to appendicitis. And if we see the picture, again, the patient's right lower quadrant, which is on our left, is where the appendix is located. It arises from the tip of the cecum, which is part of the large intestine in the right lower quadrant. And appendicitis is caused by a blockage of the appendiceal lumen. It's typically caused by fecal material, food, swollen lymph nodes, or sometimes a twisting of the organ. The blockage causes a bacterial overgrowth, typically E. coli. Bacteria then invade the wall of the appendix, which leads to inflammation, causing peritonitis or diffuse inflammation in the abdomen. And that inflammation causes ischemia, lack of blood supply to the appendix. The appendix can become gangrene or dead tissue, and the appendix can perforate. That usually takes about 72 hours. Classic signs and symptoms: migrating pain, and typically that's pain that starts at the belly button and moves to the right lower abdomen. Anorexia, loss of appetite, nausea and vomiting. Rebound tenderness, fevers. A left shift means a change in the makeup of the white blood cells found in the blood test. Right lower abdominal pain, which is an area called McBurney's point, is a classical area for appendicitis pain. Leukocytosis, or high white blood cell count above normal. And obturator or iliopsoas signs, which are basically pain with movement of the right hip. So a couple of issues with appendicitis. It's diagnosed on CAT scan. If you're CAT scanning a patient too early in the disease process, you may miss the appendicitis, like we saw with our case presentation. If you wait too long, then you may have waited for an appendix to rupture, and then the treatment becomes much more complicated. In the old days, before CAT scans were readily available, surgeon would take a patient to the operating room based on classical signs and symptoms. That led to a decent number of patients going to the operating room with normal appendixes because of less than perfect accuracy in diagnosing the appendicitis. Nowadays, with CAT scan being so readily available, it is standard and expected to have a CAT scan diagnosing appendicitis. And typically, surgeon will not take a patient to the operating room without it. So the risk and benefits of this is that CAT scan is readily available, but there is a lot of radiation exposure to patients, so we really need to select our patients carefully who have at least moderate pretest probability for appendicitis to avoid excessive radiation to patients. It is a very common and most common surgical emergency in pregnancy, which always becomes a difficult area. Pregnant women with abdominal pain very often is chalked up to pregnancy-related pain, but it's just an important thing for every ER doctor to keep in mind when they're looking at pregnant abdominal pain. So the treatment, as I mentioned, is typically surgical. Most surgeons are operating laparoscopically to remove appendicitis. They may do an open approach, which is where you make a larger incision in the right lower abdomen and remove the appendix manually. Open appendicitis, we're going to see more with complicated appendix that's ruptured, or there's a lot of scar tissue, other complicating anatomical features. More recently in the literature, there's an acceptable approach to treat patients with antibiotics alone and not do surgery. This is an approach that a surgeon needs to be intimately involved with the patient care plan, and careful patient selection is very important. Patient has to be an uncomplicated case of appendicitis. And then sometimes we're using drains put in by either a radiologist or a surgeon. If an abscess is developed around the appendix, a surgeon or radiologist may place a drain instead of removing the appendix. Additionally, we'll see drains used to treat appendicitis for patients that are very ill, extreme elderly patients that may not be able to handle the stress of a surgery. So we're going to move on to the next case, a 75-year-old male with a history of hypertension, diabetes, and smoking, with a chief complaint of sudden onset of abdominal pain and right leg numbness. On his exam, his blood pressure is normal, which is actually abnormal for a 75-year-old with a history of hypertension. We'd expect him to be hypertensive. His heart rate is a little on the high side at 110, and there's bruising on the abdomen. His blood work shows a slightly elevated white blood cell count and low hemoglobin. He's treated with morphine, gets GastroView oral contrast for a CAT scan, and is diagnosed with a leaking abdominal aortic aneurysm. The vascular surgeon is called but is over an hour away, and the patient deteriorates in the ER, has low blood pressure, there's delays to get blood transfusion, and develops cardiac arrest. And this leads us into our next topic, which is abdominal aortic aneurysm. The aorta is the largest blood vessel artery in the body, comes off of the left ventricle. There's a thoracic aorta, which supplies blood to the upper body, chest and brain, upper extremities, and an abdominal aorta, which supplies blood to the lower half of the body. The middle picture is a normal aorta, and then on our right, we see an enlarged aorta with an aneurysm. And here's a picture on CAT scan. The large circle in the middle of the belly is a dilated aorta. Abdominal aortic aneurysm is just like it sounds and looks. It's an abnormal dilation of the aorta, where the aorta is more than 50% of its normal diameter. Risk factors: smoking, advanced age, atherosclerosis, and connective tissue disorder like Marfan syndrome. And risk for rupture of the aorta is when the diameter gets above 5.5 centimeters, or if there's rapid expansion, meaning it's growing at more than half a centimeter per year. Most patients, unfortunately, are asymptomatic before the aneurysm ruptures. An astute physician may be able to identify a pulsatile mass, especially on a thin patient in the abdomen. And a scary statistic is that when these aneurysms are found, incidentally typically, only 15% of patients are getting appropriate instructions, education, and follow-up, being told that there's an aneurysm and how to monitor it. When there is a rupture, there's still a high miss rate. The signs are, it's not a very common diagnosis, and the signs can be confused with other conditions. On the exam, again, we may see feel a pulsatile mass. There may be bruising on the flanks, around the belly button, in the thigh, or on the scrotum, and we may find asymmetrical or unequal pulses in the different extremities between right and left side. The diagnosis is made either with CAT scan or bedside ultrasound, and treatment is either an open or endovascular repair. The mortality rate, even when diagnosed in the ER, is about 50% once an aneurysm is ruptured. Just going back, where's everyone still back with me here? Okay. So I'm going to stop for questions.
Yes. If I could ask the attendees to please enter the passcode. The passcode is abdominal, and also send in your questions during this time. The first question that we have is, client had pain from full area, left to right, lower abdomen area. Started left side. No vomiting, high white blood cells, small fever. One doctor said ulcerative colitis, others said diverticulitis. I was told diverticulitis was only one-sided pain, so it must have been ulcerative colitis. No? We'll also push it out to the screen so you can read it there.
Okay. Okay, client had pain So diverticulitis, and I'm going to talk about that coming up, very classically is with left-sided abdominal pain. But people can have atypical diverticulitis with right-sided abdominal pain. No vomiting. Ulcerative colitis is a diagnosis that's going to be made with a colonoscopy and biopsy. It should be very clear. It's a pathologic diagnosis, meaning you can't necessarily tell from the signs and symptoms, but the test of choice is a colonoscopy with biopsy, and that should make the diagnosis extremely clear and black and white. Does that answer the question?
Yes. Next question. To view the appendix, can an MRI be used instead of a CT scan so as to reduce radiology levels?
Yes. So that's a great question. So I had mentioned one of the difficult patient populations that we encounter would be a pregnant woman with abdominal pain. And the reason is we really want to try to avoid the radiation exposure to everybody, but especially when there's a fetus involved or we're looking at a child with abdominal pain. Certain institutions will evaluate appendicitis with MRI. Typically, we'll see that at a children's hospital or a tertiary care center. In my experience, community hospitals without very high volumes are not going to be diagnosing appendicitis or evaluating acute abdominal pain with an MRI. And I think it's an issue of volume and the radiologist exposure to the amount of volume and reads, and additionally the availability of MRI. But every abdominal CAT scan that we do, we estimate 1 in 5,000 will lead to a fatal cancer. And I think more and more the community is moving towards alternative to CAT scan for diagnosis, just that right now that's a very common tool that we use.
Would a double lung transplant from 5 years ago be a heightened risk factor?
So did the person clarify heightened risk factor for which condition, for appendicitis or just in general for mortality? I don't know. The question doesn't clarify. Okay. So a lung transplant in itself should not necessarily increase risk for specific abdominal conditions. However, anybody that's received a transplant typically is on long-term or even lifelong immune suppressant agents like steroids or other drugs that will drive down your immune system so you don't reject your organ transplant. When those types of medications are on board, patients become very high risk for infection. So some of the infectious process that we talk about, like diverticulitis, kidney infection, other abdominal infections, they become much, much more complicated. The other complications that we may see with a lung transplant patient, because the vascular structures are intervened with, it may affect some clotting in the abdomen or in the chest. So those sorts of things, the risk would be increased, but a lung transplant itself should not increase your risk for things like appendicitis or abdominal aneurysm.
Okay, many labs to consider in cases. Which ones are best to really know, research, and look for shifting?
Many labs to consider. So, I think that every time we order a test anywhere in medicine, we should ask what question is it trying to answer. So, I think that the white blood cell count is helpful as a screening tool. We typically will see elevated white blood cell count in acute physiologic stress. So there can be an infection causing an elevated white blood cell count. There can be a blockage, a heart attack, a broken ankle. So any sort of physiologic stress. But it does help to clue you in that there is some physiologic stress going on. And, other than that, I think it really becomes very specific to the type of process you're looking for. Typically in patients with abdominal pain, I'd like to see a chemistry panel to be able to look at kidney function, kidney protein levels, and electrolyte panel, sodium, potassium, chloride, because those will give you clues about hydration status and ongoing body losses, as well as infection and perfusion status.
Client has some frequent urination urge but no leaking. She slips and does the splits. She is 60 years old. She then has uncontrolled urination. Does the, method of the injury result in the injury?
Okay, I'm just going to wait for that one to come up on my screen because I missed. Client with frequent urination urge but no leaking. Slips and does the splits. She then has uncontrolled urination. So I'm interpreting this as that the patient did a split and then has frequent urination without leaking. I think that it's hard for me to answer this question. I think the question is, was there an injury from a slip that could cause frequent urination but no leaking? My initial instinct is I don't see a connection. You can have a urethral injury from pelvic trauma, which can cause leaking, but should not typically cause frequency. So I don't think without more information I can really clearly answer that, but it doesn't really seem like there's a connection between this.
Thank you. This is our last question. When the patient has a history of multiple CT scans for pancreatitis, diverticulosis, kidney stones, and other conditions, what are alternative DX procedures, and when does the CT risk become excessive?
Okay, good question. The CAT scan issue, to me, I feel very strongly, just speaking from personal experience and family, I have never had a CAT scan of my abdomen. I would try to avoid it at all costs. When there's a moderate or high probability of a diagnosis that needs to be made with CAT scan, the CAT scan should be done. So I think the important thing to take away is that when there's a real risk and there's real probability and there's not an alternative, the CAT scan should be done. When there's not, it should be avoided with very good patient education. Just talking about, pancreatitis first. Pancreatitis is typically a clinical diagnosis with a blood test, lipase, and evaluating with image the pancreas. Probably only needs to be done once, maybe not once in your life, but once maybe every few years, and that can be done with an ultrasound or an MRI. There's also other special tests called MRCP, where they look at the ducts in the liver and the pancreas to see if there's blockages. And typically for pancreatitis, patients would not need a CAT scan emergently. And again, there are other alternatives like ultrasound and MRI. Diverticulosis, every adult American has diverticulosis, once you probably get above 30 or 35 years old. As you get older, you have more and more. Diverticulitis, and we're going to talk about, is when those diverticulosis become infected. And that typically is a diagnosis that probably needs to be made on CAT scan every time, unless the patient is very reliable, has a clear history of reoccurring diverticulitis, and is not very ill. And then kidney stones I'm going to talk about as well, but there are alternative diagnostic modalities, typically ultrasound. The limitations of ultrasound for looking at kidney stones is that you may not see the stone itself, but you may see the swollen kidney or lack of swollen kidney. Additionally, an abdominal X-ray, you sometimes can see a kidney stone. Typically, they're used in conjunction, so a patient may get a CAT scan for kidney stone, and then on follow-up with the urologist may have abdominal X-rays to follow the progress down the urinary path. And, when does CAT scan become excessive? Again, personally, I think you want to try to avoid it at all costs. I think in elderly patients, 65 and older, I worry much less about the radiation risk because there's many fewer years of expected life for the radiation dosing to cause cancer, and I worry a lot more about CAT scanning a young person, especially women of childbearing age. So I really try to avoid CAT scanning with those patients. And again, about 1 in 5,000 abdominal CAT scan is going to lead to a fatal cancer. So to me, 1 is too many unless it's really crucial that you're getting that test because you're ruling out a life-threatening condition.
Okay, thank you. That was our last question for now. You can continue on with your presentation.
Okay. So let's see. Next, we're going to talk about bowel obstruction. So this picture here is an abdominal X-ray where the black spaces. Lauren, when I move my mouse, can people see my mouse or not?
No, they cannot.
Okay. So the flat horizontal lines that the arrows are pointing to are called air fluid levels. And this picture just shows that when the bowel is blocked or obstructed, stool contents cannot make their way through the intestines and they layer out and cause this air fluid level phenomenon. So what is bowel obstruction? It's just like it sounds, interruption of normal flow through the intestines. There's functional obstruction. We talked about it early with our appendicitis case, where the bowel is not squeezing properly, is not having normal peristalsis or movement. And then there's mechanical obstruction, meaning something is physically blocking the bowel from moving. The bowels get dilated, strangulated, and compromised of blood flow. That leads to necrosis and perforation, similar pathophysiology with appendicitis. The causes most commonly, almost every bowel obstruction that we see, it's from post-operative adhesions. So anybody that's ever had an abdominal operation has risk for scar tissue or adhesions in the abdomen. Those adhesions can cause blockage and obstruction of the bowel. Other less common causes, hernias, tumors, foreign bodies, and intussusception, which is like a twisting of the bowel. The signs and symptoms, nausea and vomiting, cramping, abdominal pain that comes in paroxysms, obstipation, meaning patients aren't having bowel movements or passing gas, and patients typically are going to be dehydrated, tachycardic with fast heart rate, low blood pressure, decreased urine, and sometimes with fever, they become septic. They also frequently will report or have signs of abdominal distension. So we start with an abdominal X-ray. You'll see those dilated, stretched out loops of bowel and air fluid levels. And unfortunately, it's only about 50% sensitive. So there's many patients that we will miss if we only rely on our X-rays. And CAT scan, again, is a much more sensitive test. There's closed loop obstructions, which is where there's a physical blockage above and below the affected area of bowel. Treatment initially for patients that are not very ill is going to be fluids, having them not eat or drink anything, placing a nasogastric tube to decompress their stomach, and it's important to get a surgical consultation early in the course to help manage. Patients that are ill or toxic may need portions of their bowel removed. If there's complete obstruction, they may need portions of their bowel removed. That often leaves patients with a colostomy bag. As this process gets worse, as the obstruction goes from partial to complete, the bowel becomes ischemic and necrotic and eventually can perforate. So pitfalls here, hernia identification, so failure to do a thorough exam and identify patient may have an umbilical or an inguinal hernia that can be reduced or pushed back in, and that often will resolve the obstruction. Appropriate replacement of fluids and electrolyte losses, and making sure that our surgical colleagues are on board and monitoring the patient for decompensation. So we'll look at a case of 65-year-old with pain, distension, fever, and vomiting. The x-rays do show the dilated loops of bowels. The patient's admitted to a medical service with a nasogastric tube and intravenous fluids. His blood work shows an elevated lactic acid level, which is a sign of poor tissue perfusion and sepsis, leukocytosis, which is elevated white blood cell count, and acute renal failure. The surgeon is called, but there's no reply for 8 hours. The doctor did not administer antibiotics for this septic patient. I think this just illuminates importance of consultant timeliness. So every hospital should have policies on how long a consultant has to call back and to respond to an emergency. Typically, an acute emergency that's time sensitive, the consultant would have 30 minutes to an hour to come to the ER at the ER doctor's request, and typically to call back within 15 minutes. I think this is something that comes up over and over again that I see on my reviews, is that really the decision to have the consultant come in and when they come in is at the discretion of the ER doctor. If the ER doctor finds that the case is time sensitive and emergent, the consultant is expected to come in right away. Naturally, there's there's frequently disagreement about timing, but ultimately it's the ER doctor's responsibility to make the decision on timing and expectations for bedside consultation. Here we're looking at a picture of necrotic bowel. So on our right upper portion of the screen, we see the black discoloration to the intestines, and once it gets to that point, those portions of intestines need to be removed, which leads to a colostomy bag. We're going to move on to a new case, a 40-year-old healthy marathon running female. She gets a routine endoscopy, which is a scope in the upper abdomen. She comes in with a chief complaint of upper abdominal pain, cramping, and nausea. Her heart rate is 100, which is on the upper limit of normal, except it's important to realize that a 40-year-old marathon runner should really have a resting heart rate in the 50s or 60s. She's tender in the upper abdomen. She has a normal abdominal X-ray and a lipase, which is a pancreatic enzyme of 301, just trace above normal limits. She's told to go home, bowel rest, and treated with Percocet. This is going to lead us to talk about perforation. Just want to go back to the slide. Okay. And again, this normal abdominal X-ray, this just goes back to sensitivity of abdominal X-ray for some of these conditions. On our screen now, we're looking at a chest X-ray. On the lower portion of the lungs, there are the diaphragms. On the right side, it's much easier to see. There's a thin white line going horizontally across the lower portion of the lung. And below that, we see the black space where there's air underneath. On the left side, you can also see a very thin black line below the diaphragm and right above the stomach. And this is obviously abnormal. This is air tracking up the abdomen and resting below the diaphragm. Perforation is exactly what it sounds as: extraluminal free air or fluid collection. It comes from a full thickness injury of the bowel. Most commonly, we're going to see this from either surgical iatrogenic causes, and next most commonly from ulcers and malignancy. But many other causes, penetrating trauma, anything that's a sharp trauma to the abdomen can cause this. Nasogastric tubes, endoscopies, failure to delay treatment for a bowel obstruction or blockage, ruptured appendicitis or diverticulitis, an ingestion of a corrosive agent like a battery, Boerhaave syndrome, which is an aggressive vomiting syndrome which can cause a tearing of the esophagus. So here we're looking at a small hole in the mucous membrane of the intestine, the mucosa of the intestine, and that's a perforation, looks like. It causes sudden onset of abdominal pain and then temporary dissipation of pain. May radiate to the shoulder, and that's a referred pain from diaphragm irritation. And it quickly leads to peritonitis or diffuse abdominal irritation and then sepsis. So when we're suspecting this, again, we do an upright abdominal X-ray. It's important that X-ray is upright positioned so that the air can travel up under the diaphragm. If a patient receives a flat X-ray, meaning they're lying flat on the stretcher, this may be more easily missed. And then when the suspicion is high and an X-ray is normal, then the doctor should move on to do a CAT scan. I show here conservative versus surgical treatment. Frequently, almost always, this is going to be surgical treatment to find where the hole in the intestines are and to repair the hole. And then patients should be on antibiotics. There's now going to be an abnormal communication between the intestinal tract, and the peritoneum, the inside of the abdomen. So pitfalls, failure to get an upright chest X-ray, so just relying on your flat X-ray, and just recognizing that a normal X-ray does not rule out disease. Again, the sensitivity is 50%, so if we have 10 patients come to the ER, we know all of them have an abdominal perforation. The X-ray will only identify 5 of them, and it'll miss 5. And then this is a very time-sensitive condition. Again, you're having abnormal communication between the intestines and the abdomen, which will quickly lead to peritonitis and sepsis. So really getting a surgeon involved very early is important. Our next case is a 22-year-old healthy man with flank pain radiating to the groin. His vital signs are normal, but he's writhing in pain and has mild scrotal pain on palpation. His diagnostics show 5 red blood cells in his urine, 5 to 10 white blood cells, both abnormal, and has a scrotal ultrasound which shows a varicocele. A varicocele is a benign, swollen vein sitting in the testicle. It should not cause pain. The patient is diagnosed with a urinary tract infection and a varicocele and sent home. So a couple important things just to appreciate before we move on to this topic. Young men should not get urinary infections. Elderly males might and babies might, but a 22-year-old should not develop a urine infection. That's abnormal. And men should not have red blood cells in their urine. So those are red flag that something else is going on here. Women of childbearing age or that are menstruating may have red blood cells in their urine, but when we see blood in the urine on a young man, we should think something else is going on, like a kidney stone. And in the elderly, we should think about bladder or renal cancer. So now we're going to talk about kidney stones. We see a picture of the abdomen here with 2 kidneys. Coming off the kidneys are the ureters. There's 2 ureters. They drain into the bladder. The bladder drains into the urethra, and the urethra into the toilet bowl. So nephrolithiasis, or kidney stones, or renal colic, typically made out of calcium oxalate or uric acid. There are many other types of kidney stones that make up, but these are the most common ones we see. The biggest risk factors we see are prior history of kidney stones, and just important to recognize patients that have malabsorption syndromes like gastric bypass may be at a higher risk, or gout. Many other risk factors there listed. Patients will typically have a waxing and waning pain. It goes from the flank and radiates to the testicles or labia, and then we'll see the hematuria. Just a clinical picture of a patient writhing around with classical areas of pain. It's typically not reproducible, meaning when you push on the belly, they should not have pain. Plus, the red blood cells in the urine is pathognomonic and should be enough to make the diagnosis. We will look at CAT scan, ultrasound, X-rays when the diagnosis may be uncertain. When a patient is sick, they have fever, they're toxic, where they have urine infection on top, or if it's a first-time diagnosis, so somebody that's never had a diagnosis of kidney stone before. And just a sidebar here, kidney stone or renal colic is a misnomer. Many people will have stones sitting in their kidneys. They do not cause pain. They're asymptomatic, and they may sit there for 20 years and never cause a problem. when it causes pain is when it moves out of the kidney into the ureter. And just to be aware that many patients may have a stone in the kidney, pain should not be attributed to a stone sitting in the kidney. And that's often a reason people will get themselves into trouble, is a misdiagnosis of pain coming from a stone in the kidney. Treatments, typically it's going to be NSAIDs like Toradol, Motrin, Advil, opiates when pain is severe, antibiotics when there's infection, surgical treatment when the stone is too large, and then alpha agonist agents like Flomax will help to dilate and relax the ureters to allow the stone to pass. It's important to consider stone size, so a large stone, maybe 7, 8, 9, or 10 millimeters. A small stone, 1, 2, or 3 millimeters, and then medium size. Anything above 7 or 8 millimeters, the probability that the stone passes on its own becomes small, and the probability that a urologist will need to intervene becomes larger. We may see signs of blockage by the hydronephrosis or swollen kidneys if we're looking on an ultrasound or a CAT scan, and that may indicate to us how severe the blockage is. It's important to identify patients that become uroseptic, meaning have severe urinary infection with a stone. That becomes a surgical emergency, because if that stone is not removed urgently, there's no way for that infection to get out of the body, and treatment is not going to be effective with antibiotics. That's a major pitfall, is failure to obtain a urine analysis to make sure there's not a infection on top of a kidney stone, and treating patients with antibiotics and an emergent urology consultation when necessary. We talked about red blood cells in the urine. When there are not red blood cells in the urine, it makes a kidney stone very unlikely, but there is still about a 10%. So red blood cells in the urine is about 90% sensitive for kidney stone, meaning you have a good story and red blood cells, then it's classic for kidney stone. If there's not red cells in the urine, you only have about a 10% chance that it's going to be kidney stone still. And frequently we'll see people assign alternative diagnosis with kidney stone without doing the complete evaluation. So in our case presentation, diagnosing with varicocele or urinary tract infection, when there's those red blood cells, you really need to look for kidney stone. Our next case is an 18-year-old female with history of gonorrhea who comes with vaginal spotting and missed period. Her heart rate is slightly elevated. She has mild cramping, and on a vaginal exam has a slight amount of blood at the vaginal vault. She gets an HCG level, which is a pregnancy hormone, is 3,500. She has an ultrasound which shows a questionable gestational sac, which is a sign of early pregnancy, and small amount of free fluid in the pelvis. She's discharged to home with early pregnancy, sent with prenatal vitamins, and told to follow up with an OBGYN doctor. So some major issues with this case, and we'll talk about ectopic pregnancies. Here we're looking at the female anatomy with the ovaries on the upper portions of the screen, right and left, leading to the fallopian tubes, which lead to the uterus, and then to the vaginal vault. Ectopic pregnancy is when an egg gets fertilized outside of the uterus where it's supposed to be. Most of them end up in the fallopian tube. It is common. We see it in 2 to 6% of all pregnancies, and is accounts for a high proportion of maternal deaths. Risk factors: advanced maternal age, African American, history of pelvic inflammatory disease, or previous STD. Anybody with history of tubal ligation that's pregnant, that's immediately a red flag that it may be an ectopic pregnancy. These patients come in with abdominal pain, vaginal bleeding, dizziness, and tenderness on vaginal exam. On a diagnostic evaluation, it's important to understand that the HCG hormone levels double about every 2 days in early pregnancy, and we use those levels and we correlate them with ultrasound to rule out ectopic pregnancy. There's specific dates that we can correlate with ultrasound. So on a transvaginal ultrasound, at 5 weeks, we should be seeing gestational sac, which is the early sac of pregnancy, and at 6.5 weeks, cardiac activity. Slightly later, when we do a transabdominal ultrasound. And then just important to recognize, again, the red flags. When you see an adnexal or ovarian mass in that region, and there's fluid in the pelvis, that's almost guaranteed to be an ectopic pregnancy. When you have a positive HCG with no pregnancy in the uterus, and there's free fluid in the pelvis, that's very likely to be ectopic pregnancy. Or when you have levels that are reaching up to 6,500 or higher, and you don't see a pregnancy in the uterus, it's very high risk for ectopic pregnancy. This says 100%. The treatments, OBGYN needs to be involved, and it's going to be either surgical to remove the ectopic or methotrexate, which will kill the ectopic pregnancy. If methotrexate is used on a normal pregnancy, it will also terminate a normal pregnancy, so it's important to accurately make the diagnosis. The benefit is with methotrexate is that you don't need surgery. A surgery may lead to infertility if the fallopian tubes or ovaries need to be removed to get out the ectopic. People that can be a candidate for methotrexate, they have to be reliable. They have to be reliable for follow-up. The ectopic size has to be small, and their HCG levels need to be low. You cannot have, if you see cardiac activity outside of the uterus, meaning there's an ectopic pregnancy out of the uterus that's grown to a point where there's a heartbeat, you cannot use methotrexate. If we're uncertain if a patient has an ectopic pregnancy, it's important to establish a follow-up plan with an OBGYN, and they get repeat HCG hormone levels in 48 hours and a repeat ultrasound. And if the levels are doubling appropriately, then we should start to see signs of a pregnancy in the uterus within a few days. If they're not doubling appropriately or they're declining, it needs to alert us that something else is going on. Pitfalls, failure to get that HCG level, failure to get that ultrasound and correlate the findings, failure to recognize the possibility of a heterotopic pregnancy. This is a rare condition when a woman can be pregnant with a fetus in the uterus and outside of the uterus, meaning they have an ectopic and a normal pregnancy. And failure to secure close follow-up, so to establish a follow-up plan with the OBGYN doctor or family doctor. We're going to move on to another case. This is a 65-year-old man with mid-lower abdominal pain, blood in the stool, has fever, an elevated white blood cell count, white blood cells in the urine, and nitrites in the urine, which is a protein that we see in urinary tract infections. He's diagnosed with a urinary tract infection and treated with Bactrim for 3 days. So just a few immediate red flags with this case. Again, we don't typically see men develop urinary infections at this age. A urinary infection, unless it's spread to the kidneys, should not cause fever or such a high white blood cell count. And it should not cause blood in the stool. So somebody during the initial Q&A had asked about diverticulitis. This is our next topic. Here we're looking at a picture of the intestines and little small pouches that come off the intestines called diverticuli or diverticula. And when patients have diverticula, they have diverticulosis. When those diverticulosis get inflamed or infected, they have diverticulitis. It's, as I mentioned, inflammation of diverticula in the wall of the intestines. Typically, but not always, we're going to see pain in the left lower abdomen, nausea, constipation, fever, bloody stools, and risk factors, obesity, sedentary lifestyle, smoking, or personal family history. Patients will have tenderness on palpation, high white blood cell count, and typically the diagnosis will be confirmed with a CAT scan. Treatment starts with antibiotics and also may require surgery to remove infected bowel. Patients that are elderly or are acutely ill with fever, signs of sepsis, or that cannot take antibiotics should be hospitalized. Patients that do not have reliable follow-up should be hospitalized. Surgery typically is reserved for patients that are very sick with infected bowel or getting reoccurring episodes of diverticulitis. Important that after patients recover, they should be following up with a gastroenterologist to have a colonoscopy to rule out that there's an alternative diagnosis such as cancer. Pitfalls, failure to recognize when there's an abscess or a perforation in the intestines, failure to get the surgeon involved on a patient that's sick with diverticulitis, and failure to instruct the patient that they will need to see a gastroenterologist for colonoscopy for cancer screening. And this is a very common diagnosis, huge cost to the healthcare system. I believe this is our last case. It's an 85-year-old female, history of atrial fibrillation, abdominal cramping after eating, pain out of proportion to exam, meaning that she describes her pain as more severe than she appears to be in pain. Her BUN and creatinine, which are kidney proteins, are elevated. Her lipase level, which is a pancreatic enzyme, is slightly elevated at 305. And she's treated with an antacid, intravenous fluids, told to avoid spicy foods, and sent home. Of note, lactic acid was not done, which is a sign of tissue perfusion, and no CAT scan. So again, we remember that elderly patients have a much higher mortality rate, and this patient was in severe pain with multiple risk factors for abdominal pathology. We're going to talk about mesenteric ischemia here. This is a picture of the blood supply to the intestines. On the right hand, there's a shot of a blood clot in the intestinal arteries leading to necrotic tissue, and you can see the black spots there. Mesenteric ischemia is injury to the small intestines because of lack of blood supply. Risk factors: atrial fibrillation, heart failure, kidney failure, previous heart attack, a procoagulable state, meaning you're at risk for clotting, or advanced age. It causes abdominal pain, bloody stools, and a late finding would be septic shock. On diagnostics and exam, we're going to see high white count, elevated lactic acidosis because of poor tissue perfusion, and fast heartbeat. And on CAT scan, which needs to be done with intravenous contrast, we're going to see mesenteric or edema, swelling of the intestinal wall, dilation of the bowel, and sometimes gas in the intestinal wall. Diagnosis also can be made with a special type of picture called an angiography, and treatment is going to be stenting, blood thinners, fluid, and surgery. 5 in 100,000 patients in the Western world. Mortality is very high, up to 80% for an arterial thrombus, and gangrene will set in quickly, 12 to 24 hours, so this needs to be identified and treated quickly. And pitfalls in this case: interpretation of lipase. Again, I mentioned it was a pancreatic enzyme. A few other things can cause elevated lipase, and mesenteric ischemia is one of them. Failure to get a lactic acidosis for a patient at risk. So an elevated lactic may have clued in the doctor to order the specific type of CAT scan to best evaluate for this condition. So just to kind of recap general pitfalls for abdominal emergencies, we have to consider the high-risk features. So every case I review, I'm looking for the red flag features, the abnormal vital signs, the abnormal blood work that was not investigated, the abnormal historical features. Very important to educate patients on symptoms to return and the importance of follow-up. Abdominal pain is a very dynamic process. It changes with time. We very frequently see a patient with normal exam and blood work on day 1, and on day 2 things have changed completely. So it's important that patients understand that just because they're discharged, it does not mean there's something going on that may be brewing in their abdomen. Consultant turfing and failure to respond. It's important, again, the ER doctor needs to be the advocate for the patient, and if they feel an urgent consult is needed, need to stand up for the consultant request. And then just documentation, making sure that we document, why we did or did not do a certain test. Did we do shared decision-making, discuss, the concept of not doing a CAT scan and having the patient return if things get worse. Failure to do rectal and pelvic exam, really failure to do a thorough abdominal exam. Every patient needs to be undressed and have a thorough abdominal exam. And finally, failure to arrange appropriate follow-up. Again, on the incidental findings, on the symptoms to return, and further evaluation. I believe that is my last slide, so I'll take any further questions.
Thank you. We're now entering the last Q&A. During this time, please enter the passcode. The passcode is abdominal. The first question we have is, upon a CT suspecting of appendicitis, how long is appropriate for a patient to wait to be seen by a physician or GI surgeon?
I think that my expectation would be the patient should be seen within a few hours, meaning 2 or 3 or 4 hours at maximum. And I think that surgery should be arranged, within, and I don't think there's a magic number, but I think within 12 hours. The caveat is that during that time, the patient needs to be closely monitored. If symptoms are getting much worse, the surgeon needs to be reconsulted to be updated. Again, the process of ruptured appendix, typically we're looking at about 72 hours, so it's not lights and sirens to the operating room, but my expectation would be within 12 hours the patient should be in the operating room.
Next question. Sending patient home with improper diagnosis can be fatal or present with major complications later. Is there a surefire test that should be done to avoid this?
I wish that there was. I think that emergency medicine is just a minefield. Medicine is a minefield. Even with CAT scanning every single patient, you're still going to miss things. I think that every patient deserves a very careful history exam and thought process, and very careful instructions about the things for which to return, and really that an initial evaluation in the ER that leads to abdominal pain, NOS, or not otherwise specified, does not mean that something will not be developing, and that proper follow-up is very important. So right now there's really no silver bullet, and we very frequently have patients return to the ER next day, next week, where a diagnosis is made. And so unfortunately sometimes the surefire way is a tincture of time and getting a second or third opportunity to make the diagnosis.
Next question. Should one evaluate with a colonoscopy a 69-year-old with 5 days of obstruction, distended abdomen, and known abdominal adhesions pressing on bowel?
So no, colonoscopy would not typically be used in that scenario. Again, obstruction or blockage of the intestines will lead to the distended abdomen and maybe cause from adhesions. Typically, if the bowel obstruction is not being resolved by a nasogastric tube and having the patient not eat or drink, the treatment of choice would be a surgical exploration to break up the adhesions. So the surgeon would actually go into the abdomen and try to break down the adhesions. A colonoscopy would not be very helpful for that scenario because it would not be able to reach those adhesions.
Okay, last question. Post-abdominal surgery, what are the duties of a doctor to discover a fluid leak in the abdominal cavity caused by a nick of a part during surgery or a leaking incision?
So I think that's important. Obviously that can be a dangerous complication of surgery. There can be, like this person asked, leaking body fluids. It can lead to infection. It can lead to abdominal fistulas. It can lead to continued pain, poor wound healing. So it's important. Anybody that's recently had surgery, abdominal surgery, I do believe that the emergency physician needs to be communicating with their surgeon. The surgeon will know much better the anatomy of where they were operating on and the structures that were at risk and the structures they may have been instrumenting. And so I think the duty is to speak with the surgeon and to consider pathology, especially in any of the anatomic areas that the surgeon may have been operating on. But just,
okay, thank you.
Go ahead.
That was unfortunately the last question that we have time for today, so we'll send any unanswered questions over to you and you can respond to them directly.
Terrific. Thank you.
Please remember that if you're applying for CLE credit, you must have attended for the full 60 minutes of the presentation. You are also required to complete the survey at the end of the program. Please note you will be receiving your certificates via email in 24 to 48 hours after the presentation. In addition to being your best source for testifying and consulting experts for more than 60 years, TASA also offers free interactive webinars, expert written articles, research reports on expert witnesses such as the Challenge History Report 2.0 and the Expert Profile 360. I want to take this opportunity to thank everyone for attending and most especially Dr. Evan Cohen for his time and effort in creating this presentation. If you would like to speak with Evan or if you would like to speak with a TASA representative regarding an expert witness for a case that you are working on, please contact TASA 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. This concludes our program for today.